We're back.
Hi.
So we're just having a conversation here because this information is so relevant and it's so interesting to me because really when we do any test, we want to do a test for two reasons. One, to give us a heads up that there may be something going on that we don't know about. Mm-hmm. And B, so that we could actually do something actively to interrupt or intercept the trajectory of the way things are currently going for your health. Mm-hmm. So in this this part of our video series, we want to talk about what would be the blood indicators that would alert you and I as doctors to the fact that a patient may be at risk for having a heart attack or a stroke. So that's what we want to get to the bottom of. This is all the conversation we've had to this point about cholesterol. And to determine whether or not testing for cholesterol is useful, and if so, which particular tests are going to give us the most useful information. So let's summarize that.
So which tests are the most useful? I would certainly say, again, either ApoB.
Okay, so I would grab a pen and a pad of paper and jot this down because these would be tests that you might have to ask to be performed.
You probably would.
Yes.
Yeah. So either ApoB, let's just ApoB, or NMR, lipoprofile.
Yeah.
NMR, nuclear magnetic resonance. But what the lipoprofile does is it breaks a lot of things down, and in that profile, the most important component to look at is the LDL-p.
LDL-p. Remember, the LDL-p are the dump trucks, not the gravel. And normally when you have your cholesterol tested, you're having the amount of gravel tested,
typically.
And it's the dump trucks that we're most concerned about.
Because if you've got a bunch of them on one side and very few on the other side, they're going to want to go somewhere. So that's why it's dangerous to have more dump trucks than it would be to have more cholesterol within them.
And where do they want to go? Well,
into that endothelial space.
Into that space where they shouldn't be, and that's where they cause all the problems.
Yeah.
Okay.
So you would want to again have your either ApoB or LDL-p done. The LDL-p is done through NMR, that NMR lipoprofile test, and then you would probably want to get LP little a, so it's just lipoprotein LP and a small a in brackets. LP little a, just to make sure that it's not high, so that you're not in that genetic proportion that synthesizes more of it, because it also predisposes you. And then you want to say, okay, so is my LP little a high? If it is, that's a problem. Is my LDL-p high? If it is, that's a problem.
Too many dump trucks.
Too many dump trucks is a problem. Or if you didn't do the LDL-p and you did ApoB, is your ApoB high? Because it tells you indirectly if your LDL-p is high. And then you'd probably want to get something like CRP or high sensitivity CRP done, just to see what your general inflammation is. And there's a whole slew of nutrient testing that could be done, but those are the most important factors.
Yeah. As it relates to this whole cholesterol issue, these are the most useful tests, the most applicable tests. Right.
For predicting risk. It doesn't mean you're currently at risk, but it's your long-term risk assessment. So it would be, currently these things aren't a part of like the Framingham or other kind of risk scoring, but they should be, and I think that they will be. I think the standard will change eventually, but as of right now, this is the best thing you could do.
So just to clarify, you said it doesn't mean that you are currently at risk, but it means that you could become at risk. Do you want to just clarify what you mean there?
It doesn't mean like if these numbers are high, you have risk of an event happening now.
So you're not saying that if I was to have this tested and they were high, that I'm like a walking time bomb, a ticking time bomb, that I'm about to have a heart attack in a minute?
Yeah, that's more like where the carotid Doppler and seeing how much calcium there is deposited in your arteries. That's where those methods come in, because they tell you right now what your present risk is, if you're at high risk or not. Whereas these things tell you if you're on the path right, of
Right.
risk of getting
Right.
to a point
Right.
where that is. So
Right.
I don't know if it's a 5-year or 10-year. I couldn't honestly say right now, but for sure, if these markers are high, you're setting up the stage for atherosclerosis. And as we age, we know from our Framingham risk score, as we age is probably the most consistently predictable aspect of atherosclerosis, because you've got more time to be exposed to these
Exactly.
things in this
Yeah.
deposition. So it's important to have these things stay low over time.
Which, of course, very much plays into the whole concept of the proactive health model, which is what we consider ourselves really good at, which is having a look at these markers. If they're high, then making lifestyle changes,
do something about it.
modifications. Let's intercept and keep monitoring and watch that these markers are improving over time.
And that's where diet comes in. That's where maybe even being on a statin comes in. That's where certain medications could be helpful, or certain lifestyle modifications, but at least knowing that it's worth putting the effort into or needing something.
Right.
That's where it really comes into value.
Awesome.
Yeah.
So we are going to summarize. We've gone through a lot of information over these last few videos, and I want us to distill this down into a takeaway so that you have a really clear understanding of the whole concept of cholesterol, so that you could share this information with your friends at the next cocktail party.
Get your LDL-p figured out, or
Yeah.
your ApoB. Get your LP little a done. Those are probably
Yes.
the best places to start.
All right, check back with us.